We are really excited to have everybody here. We have a lot of familiar faces and a lot of new people joining us. I just wanted to go over our agenda. I'm going to just do a brief introduction, followed by our keynote address by Dr. Giovanni Volpicelli. We have some updates from our president, Dr. Charisse Kwan, and research updates from Kathryn Pade, announcements from members, some cool cases from members, and then and that's the official end of our conference agenda. But for those who would like to stay, we have a discussion about future research projects being led by Dr. Sam Lamb. I just want to put up here, we would like you, if you could please complete a survey after the conference. You can just use your phone to scan the QR code here, and that will bring up the survey. I have a few more QR codes posted throughout the presentation so that you will be able to, you can get that on your phone and then you can tag it to your computer. And just before we start, if everybody could just identify themselves and tell us who you are so we have an idea who is joining us today. We'll just give that a minute. All right, we're at about 2/3 responding. So tell us who you are so we know who is joining us today. All right, we're going to give that another 10 more seconds and then we're going to close the poll. All right, so most of us I see here are from pediatric emergency medicine, but we have a nice attendance from emergency medicine. We have fellows in POCUS and pediatric emergency medicine, as well as a few pediatricians, radiologists, and some residents. All right. So, you know, when we last met in the spring, I know that our colleagues in the Northeast and in Europe had really been through dealing with coronavirus, and many of us had not. And it's been a long couple of months for us. So everybody take a nice deep breath, and hopefully in the next couple of hours, we'll have a little bit of time to unwind and then let it out. I know that's how I feel when I'm wearing my glasses. So when we were last together in the spring, it was predicted that this fall there would be a second wave and that this fall would be pretty bad, which is unfortunately what we're seeing. And this is from the New York Times. This is a couple weeks old, but it is still continuing to trend up. This represents the United States. And this is the case fatality rate, which fortunately has been going down despite the increased number of cases, because over these months we have learned how to better manage this illness. And you can see that a similar pattern in Europe, with France and Italy leading over there. And then that same case fatality rate has been improving. This morning we have the immense opportunity to hear from one of the great leaders in emergency ultrasound, who has really been leading the charge and how to use ultrasound in managing this illness. And I'd like to invite Dr. Niccolò Parri to introduce our speaker.
So thank you for this. It's my pleasure to introduce Giovanni Volpicelli. There are several ways to describe who is Volpicelli and summarize his activities. So probably the most honest is that Giovanni is an emergency physician working in San Luigi Gonzaga University Hospital in Turin, and currently he's working on the floor taking care of hundreds of COVID-19 patients during our second wave. But this description doesn't give the full credits of his scientific activities, because Giovanni is one of the big names in lung ultrasound. He led scientific committee on the first international consensus conference on lung ultrasound. He directs international teaching program on emergency and critical care ultrasound. He's a member of the board of directors of WinFocus. He's editor of 2 journals, and most importantly, of editor-in-chief of the Ultrasound Journal. So in a sentence, he's the right one to tell you what's new in lung ultrasound during the COVID-19 pandemic.
Thank you, Niccolò. Thank you for introducing me. And especially thank you for having invited me in this webinar. You know, I am an emergency physician working in a hospital caring adult patients. I don't see so many pediatric patients. But as it is the history of lung ultrasound that what is useful in adult patients is also useful in pediatric patients. And the same is for COVID-19. My presentation will start from what is already reported in these main papers that have been recently published in Intensive Care Medicine, in the Ultrasound Journal, and in CHEST. What we did was just to try to standardize a protocol for the first early examination of patients suspected for COVID-19. That is the main problem that we are facing in these days, because in our hospitals, we are just having a surge of patients coming to the hospital with symptoms suspected for COVID-19. But before understanding what is, and in my presentation, we will talk about first a general framework of COVID-19, what is the epidemiology and prevalence, just a few words about that, COVID-19. That is very important to understand the role of chest imaging. Then we talk briefly about the technique, the signs that we use to make the diagnosis, the patterns of probability, the phenotypes, how we can combine patterns and phenotypes to make a safe triaging of patients. And then last topic is the way to quantify and monitoring COVID-19 pneumonia in our patients. So first, the general framework of COVID-19, just a few words to understand that COVID-19 is a disease giving very dangerous problems to our health systems. Why? For a simple reason, COVID-19 is not a severe disease most of the cases. I report here some percentages. Of course, don't look the details of the numbers. They are changing time by time. But this is a good general view to understand what is the epidemiology of the disease. As you can see, most of the time, the disease gives an infection without symptoms. Only a minority of patients have a severe condition with pneumonia, and that is the main complication of this disease. And only a very small percentage will be admitted to the hospital with a severe pneumonia, and even less will go to the intensive care in the intensive care unit. And the mortality of the disease is not that high if we compare, for instance, this viral disease with some other diseases like Ebola, for instance. But where is the danger of the disease? It is inside these numbers, because the fact that most of the time the disease gives an infection without symptoms is a great opportunity for the virus to spread among the population. And because of that, these small percentages of severe pneumonia become a high number of patients coming at the same time in the hospitals, in our hospitals, with the need to be admitted and cared, even in the very few places that we have in our intensive care units. And also the problem is that we don't see the end of this pandemic, that maybe will be just the advent of the vaccine that will, I hope, will be very soon. What is the role of chest imaging in this? Of course, it cannot be a role of an epidemiologic role. So we cannot use chest imaging to make the diagnosis of COVID-19. This is a strategic error that I saw in the months following the first surge, the first outbreak that we had in Italy. It is a strategic error using lung ultrasound and more CAT scan to screen patients with and without COVID-19 in the hospitals. It is not possible because, of course, most of the patients will have the disease without pneumonia. And even the opposite. So many patients will have pneumonia without other symptoms, without strong, severe symptoms. So the role of chest imaging should be just to make the diagnosis of pneumonia in the hospital. And the rest of the work should be done in the territory, that is identifying cases, identifying positivities, and using the swab test and RT-PCR to identify positivity to the infection. The other point that is very important is that this disease taught us that the behavior is in waves. So we assisted in Europe, at least in Italy, to the first wave that was around March and April. And after the first wave, the prevalence of the disease fell down totally. And this is what happened in my hospital. After May, in June and July, the number of patients hospitalized with COVID-19 were very close to zero. And most of the tests, diagnostic tests we were doing in our patients were negative. So this means that the prevalence is changing. And because the prevalence changes, the accuracy of our diagnostic tests will change. So the consideration of the signs of lung ultrasound that we had in March and April must be different when the prevalence of the disease is close to zero. The same signs have a good sensitivity and specificity during the high prevalence, but specificity and sensitivity goes down when the prevalence of the disease is less. These 2 points are 2 main points to think about during this second wave, and probably during the moment when the second wave will finish and we will wait for the third wave that probably will happen. So that said, just a few words about the technique of lung ultrasound that we use. When we first started to examine patients during the first surge of COVID-19, we understood very quickly that the technique in the emergency department needed to be adapted to the situation. Why? For the simple reason that we had the problem of protections. So we needed to examine patients in a very quick way. There were many patients to examine and we had no time to spend. So the technique for lung ultrasound needs to be quick and safe at the same time. The problem of course, of pneumonia, interstitial pneumonia from COVID-19 is that the signs of the pneumonia can be found in any part of the chest. So the technique must be quick, but at the same time must be comprehensive of the examination of the whole chest. including the anterior chest, the lateral chest, and the posterior chest. We have two main possibilities of scans. The longitudinal scan on the left side, where you see many spaces, many intercostal spaces, and the oblique scan, when you see a larger part of the lung. Our suggestion is to use always the longitudinal scan to be quicker, of course, and to turn the probe to the oblique scan only in that part of the chest where you see some signs that you want to examine better. So you want to visualize more in detail. What we do is just using 4 main scans, and we record 4 clips of around 10 seconds. The first one in the anterior chest, sliding down in longitudinal scan to see all the 4 or 5 spaces that we can see in that part. Of course, in the children, this can be done much quicker. In 10 seconds, you have the time to go down and go up again, like in a VU. That allows you to visualize most of the anterior part of the chest. The same we do in the second scan, that is in the lateral chest. And then we ask the patient to turn a little bit in the lateral decubitus, and we scan the posterior chest in the third video along the space that we have between the scapula and the spine. And then the fourth video, we do oblique scans below the scapula to see all the remaining spaces that are in that part of the chest corresponding to the base of the lung. Then we repeat the same on the other side. We have so a total amount of 8 clips that we should record, if we can, of course, or we can just annotate what we see during the examination. Just one small suggestion, it's a tip. So it is very important to orientate the probe in the right way, because as you can see, just moving the probe a little bit by tilting, the pleura disappears, and we have not enough visibility of the lung. So the best position is the one that we find by tilting the probe, where the pleural line is more echoic, that you can see in this video appears and disappears just by changing the orientation of the probe. This is crucial in lung ultrasound, and maybe not enough reported in papers and in books about lung ultrasound. It is extremely important, especially in the posterior chest, in the dorsal scan. Now, which signs we should examine? Of course, you know, COVID-19 pneumonia is an interstitial pneumonia. So the main actors in COVID-19 pneumonia are the B lines, of course. So the first sign, the most important sign that we should notice, that we should diagnose, are the B lines. What kind of B lines? We saw that it is very important to distinguish 3 kinds of B lines, 3 possibilities. One is to see B lines, like in this clip, separated one from the other. Why it is important? It is extremely important because we will see these B lines separated, multiple and separated, in most of our patients with COVID-19 pneumonia. But this sign is also visible in other diseases of the lung, of course, like in edema of the lung, in RDS, in fibrosis. So it is important to have a look to this kind of B-lines when separated or when coalescent, like in this video, the same patient in another area. You see some B-lines tend to merge one with the other, giving an image more echoic that is called coalescence of B-lines. Of course, in the history of lung ultrasound, we know very well that this corresponds to a most severe degree of loss of aeration of the lung. But it doesn't matter. We will see that it's not so important in COVID-19. Anyway, these are two typical behavior of B-lines in any interstitial disease. That said, we noticed that in our patients with COVID-19 pneumonia, there is another sign that in our opinion is very important to distinguish. We will see why it is very important. It was called the light beam. What is the light beam? Of course, it is formed by B-lines, but in this case, and differently from coalescent B-lines, the light beam is a band, an echoic band, very large, with, of course, different size, that sometimes, as you can see in this clip, appears and disappears. Like in the lighthouse that you see in the animation there in the picture on the left. Why it is important? First, it is important because we speculate that this is typical of the very early aggression of the virus and all the phenomenon that the virus will start in the lung, very early aggression, very early attack of the virus to the lung periphery. That should correspond, in our speculation, to the ground glass areas that you see in the CAT scan at the beginning, very smooth areas, ground glass, involving especially the periphery. And this is typical because, as you can see, this part has, in ultrasound, a very sharp border with the normal lung. So you see alternance of normal aerated lung with the light beam. That again is a sign of very early condition of the disease. And this is extremely important, in my opinion, in my personal opinion, when you perform the early approach to suspected cases. So patients, especially in the emergency department. As you can see, this is also demonstrated by the fact that the pleura in these areas many times is regular, is not irregular. So you have a regular pleural line. That means that still the interstitial disease is not in the advanced, in an advanced situation. Of course, the light beam can be also observed. This is another example. You see this light is absolutely amazingly apparent. And it is the first thing that you will see in patients in the emergency department, and you will be totally amazed by this sign, but because it is a typical sign of the disease. Be careful, I say typical and not specific. It is a great difference between typical and specific. We cannot say specific because we can say the same sign in other diseases, but we say typical because most of the patients with COVID-19 pneumonia will show this sign. Sometimes the light beam can be also seen of course, in the middle of a coalescence of B-lines, of separated B-lines, and sometimes even together with the irregularity of the pleural line. It is very important because the regularity of the pleural line, be careful, not thickened pleural lines. It is an error to say thickening of the pleural line. Lung ultrasound cannot assess the thickness of the pleural line. We can only assess the regularity of the pleural line. Like in this case, the irregularity of the pleural line is a sign of an interstitial involvement, peripheral involvement of the lung. So it is also another typical sign of COVID-19 pneumonia. Again, not specific because we see irregularity of the pleural line in many other conditions, but most of the patients with COVID-19 pneumonia will show areas where the pleural line is irregular. Sometimes this irregularity is so heavy, so that we can say also fragmentation of the pleural line, like in this case. Anyway, there is no difference. Fragmentation of irregularity are two conditions typical of the interstitial pneumonia from COVID-19. Another typical sign of the disease is the presence of peripheral consolidation. So we see small consolidations in the periphery of the lung, sometimes even with the bronchograms, like in this case. And again, this is another sign of a pathology, a condition of the lung, of the interstitial, of the interstitium of the lung in the periphery. The other sign that is very important for us to observe is the possibility of large consolidation, sometimes lobar consolidation, with air bronchograms, like we see in this clip. Of course, in COVID-19, especially in the advanced situation of COVID-19 pneumonia, it is common to see large consolidations. But when the large consolidation with air bronchogram is isolated and only one lung, this has a negative predictive value for COVID-19 pneumonia because it is a typical sign of bacterial pneumonia. So it is possible to observe this sign in COVID-19, but we must observe in the rest of the lung a lot of other interstitial signs. Otherwise, the value of this pattern is totally the opposite. The same can be said for effusion. In COVID-19 pneumonia, we may observe effusion, but usually very small and not giving phenomenon of atelectasis of the base of the lung like it is observed in this clip. So a large effusion has a negative predictive value for COVID-19 pneumonia. Now, this is the list of the main signs that we should observe when we do a diagnostic process for COVID-19. I forgot to say, if you have questions, you can stop me in any moment. Or the questions will be at the end, I don't know. Let me know. So signs of...
Can I interrupt you for just a minute?
Yes, of course.
So we had one question about the light beam. How do you distinguish the light beam from probe position that might affect the appearance or disappearance?
Sorry, from what?
So how do you distinguish the light beam from signs that you might see from regular moving the probe, that if you were moving the probe, you might see it appear and disappear?
The phenomenon of appearing and disappearing should be observed with the probe still in the same position. And during the respiration, what happens is that the lung moves below the probe. And what you observe that is typical is alternance, abrupt alternance of A lines, so normal lung, with the light beam. It is typical because it is the sign that in that lung is what is going on is an acute phase, an early aggression of the disease to the periphery of the lung, because there is this abrupt border between a normal aerated lung and the ground glass area. That is the same that we observe in CAT scan. Did I respond? It's okay.
Yes. I have one more question right now.
Yes.
So we see the similar spectrum of B lines and pleural irregularity and viral illnesses in kids a lot. And these children look clinically well most of the time. What is the clinical picture of the patient in the different severity of the B lines, whether they're subpleural or peripheral consolidations for patients with COVID-19?
I cannot respond about severity. I don't believe that a lung ultrasound, but it is a long discussion, that lung ultrasound can tell us the severity of the disease. I don't believe that. I don't believe, for instance, in the scoring of by lung ultrasound and link between the scoring, correlation between the scoring and the prognosis of the patient. Of course, what we observe in COVID-19 pneumonia can be observed in many other diseases. And for instance, I received many questions or many concerns about cases of, I don't know, mycoplasma pneumonia or other viral pneumonia. But what is the problem? First, signs are not enough. We will talk about patterns and combination between patterns and phenotypes. But the other point is that we are living now a surge, a pandemic of COVID-19 pneumonia. We are not living a pandemic of mycoplasma pneumonia. We are not living a pandemic of H1N1 pneumonia. We are living a pandemic with a great prevalence of the disease of COVID-19 pneumonia. So this should not be a worry for us in the emergency department. We are in the emergency, we emergency physicians are very basic physicians, and we work with probabilities, and we don't observe details. It is enough in this situation to observe the patient and to look for typical, not specific, but typical signs of the disease to make the diagnostic process, to finalize the diagnostic process. Okay, that said, so this last question was useful to understand that signs alone are not enough for us. We need to combine signs in patterns. And patterns are, in lung ultrasound, patterns of probability, because lung ultrasound is not a perfect tool, of course. Is a tool with defects, limitations in sensitivity and specificity for lung conditions. So the combination of signs is our tool, is our possibility that we have to increase the power of lung ultrasound. And what kind of patterns are useful? We have four patterns. The first pattern, the most important, is the high probability pattern. What means high probability? It means that we see a condition in the whole lung that allows us to say, well, it is highly probable that this patient has COVID-19 pneumonia, because the condition that we observe, the situation that we observe is typical of the disease. How to describe the high probability pattern? It is much more difficult to describe in words than to have the visual impression of what you see. When we started observing the patients, the common opinion of my colleagues, of me and my colleagues, was that just putting the probe in a few seconds in the chest, on the chest of the patient, we were thinking, that's it. This patient has pneumonia from COVID-19, of course, in suspected cases. So the problem was to transform this mental idea in words. That was the main difficult problem to publish a paper and to carry on studies. We found this definition that, in my opinion, is the best that we can say in this moment about lung ultrasound for COVID-19. The high probability is presence bilateral, of course, of clusters of many of those signs that I told you all together in different parts of the lung with a patchy distribution. So we will observe multiple B lines, both separated and coalescent, the light beam, that is very typical, regular and irregular pleural line, small consolidations, and sometimes even large consolidations all together in clusters in a patchy distribution bilateral. I think that it is, to date, for what we know, it is the only way that we can describe the high probability pattern for COVID-19 pneumonia. When we talk about high probability, there must be also an intermediate step of probability, that is the intermediate probability pattern. In this case, we see similar signs, so cluster, but isolated in one lung. So when we observe only one lung distribution of these clusters, or even one isolated cluster, we cannot say high probability pattern. We must say something, we must conclude that there is a lower probability of the pneumonia from COVID-19. Or for instance, we can see in this case some B lines, but again with a unilateral distribution, or even small consolidations, again without the picture that I told you with many multiple clusters with patchy distribution. It is also important to give to lung ultrasound a negative predictive value, and it is possible because we can observe other signs that are not typical of the disease. And this is what we call it alternative probability pattern, or alternate. I don't know in English if it is more correct to say alternative or alternate, but anyway, because in Italian they have two different meanings, I prefer to use alternative. This pattern, for instance, I told you, talking about the signs, the large consolidation, lobar distribution of one consolidation isolated in one lung with air bronchogram allows us to rule out COVID-19 pneumonia. Or the other possibility is a large effusion. That is another condition of the lung. It's not compatible with the diagnosis of COVID-19 pneumonia. Other patterns that are alternative are the presence of B lines, bilateral, diffuse, but in a homogeneous distribution. Sometimes gravity related, that we observe in the compensated heart failure, for instance. And it's not typical of COVID-19 pneumonia. Another condition that should be observed to finalize the diagnosis of alternative is, for instance, the correlation between the severity of the condition and the situation of the patient. in pulmonary edema, there must be a correlation between the B lines, multiple and diffuse bilateral diffusion of the B lines, and the severity of the clinical condition of the patient. So, severe condition of the patient, many B lines that we observe everywhere, homogeneously distributed in the two lungs. And this is highly predictive of cardiogenic edema, and it's not typical of COVID-19 pneumonia. Finally, the last pattern that is very important also is what we call it the low probability pattern. Of course, absence of any sign, interstitial sign of, so just B line, A lines, sorry. So a normal pattern all over the lung. Why we said low probability and not negative? For one simple reason, that lung ultrasound is not a gold standard for chest imaging. So we may have pneumonia that is not visible by lung ultrasound. For instance, when the lesions do not touch the lung periphery. This is invisible for lung ultrasound, but is still visible for CAT scan. So CAT scan is the gold standard, and they can use in the language negative. We cannot use negative. We should use low probability. Anyway, it is very important to notice and this is, I cannot bring to you data, but we are analyzing in our study what will, and we will publish the data, but to date, I can say that when you have a low probability pattern by lung ultrasound, you cannot rule out 100% pneumonia from COVID-19, but you can rule out a significant pneumonia from COVID-19. That means that you have a condition that is prognostically not so bad for the patient anyway, even if there is a false negative condition of lung ultrasound. It was a case that after we published these 4 probability patterns, there was another publication from the Radiological Society of North America. It is an expert consensus statement where they fixed the language to be used to describe findings in CAT scan related to COVID-19. And they used also 4 different steps in the definition of COVID-19 that are corresponding exactly, of course, with a different methodology, to what we classified in lung ultrasound. So the high probability pattern is their typical appearance, bilateral patchy distribution of ground glass areas. The intermediate probability is what they call it indeterminate appearance. So unilateral, for instance, or anyway, not distributed in the same way as typical. The alternative pattern that they call it atypical appearance, that is something that gives to you information about an alternative diagnosis to COVID-19 pneumonia. And finally, what I told you, so the low probability for us that is negative for CAT scan. Is it enough? Again, if you have questions, please stop me. Is it enough? It is not. Why not? Because it is crucial for us to link the patterns with different kind of patients. And this clinical link of lung ultrasound is the core and the secret, I say, of the usefulness of lung ultrasound. That was done for all the other diseases, and the same is for COVID-19. What kind of clinical phenotypes? Well, we just focus our attention on the presentation clinical signs. So the signs that the patient tells you and demonstrates in the first approach in the emergency department. So it's not a real clinical condition of COVID-19. is the clinical presentation of patients suspected for COVID-19. They have been called phenotypes, and we have three main phenotypes. The first one is the severe phenotype. What means severe? It means that the patient shows respiratory failure signs, so respiratory symptoms, with oxygen saturation below a limit, with walking test positive, or in the most severe situations, a severe respiratory distress. So all these patients are included in one unique group that is called severe phenotype. The second group is the mild phenotype, so patients without respiratory failure, so with mild form of the disease, just for instance, cough, fever, and all the other signs typical of the disease. And finally, in my opinion, the most important group, that is the mixed phenotype. That means patients with pre-existing chronic diseases involving the lung, so cardiac and pulmonary diseases. These patients are very common in our departments, of course, in emergency. And it is a challenge in these patients to distinguish what is exacerbation of some chronic disease or the acute phase of COVID-19. Combination of phenotypes and patterns allows you to allocate the patient in the hospital, to be quick in the decision-making about how to manage the patient, where to put the patient inside the hospital, where you need to isolate, for instance, patients with COVID-19 from patients without COVID-19, or allocating patients in the grid zone, so waiting for further confirmation. So this is called triaging. That is a key point in the management of the surge of this pandemic. We published some flow charts in intensive care medicine. So the combination of in each of these phenotypes of different lung ultrasound patterns. I will show you quickly the three flow chart. You can examine in detail just by reading the paper. Of course, they should be adapted to the situation, the local situation of the hospital where you work. So each institution has rules and the different possibilities, space to be used for patients. Sometimes the space is not enough, so you cannot have gray zones, for instance, or other, or you cannot even isolate in the emergency department patients. So it should be adapted to the local condition. Anyway, what I wanted to take your attention about is this is the same work that we did in chest, thanks to my colleagues from US. We just made this table with explanations for each combination. Just a few points. For instance, when we have a combination of high probability pattern in patients with respiratory failure, of course, this is most of the time enough for us in a moment of high prevalence of the disease, like the one we are living today, to conclude the diagnostic process. We don't need anything more, especially in an era where unfortunately, the RT-PCR test is not enough sensitive. So we had patients with the first test negative in presence of a very suggestive clinical and imaging picture of the disease. So in this case, of course, this combination should be enough to consider the patient COVID-19 pneumonia. The opposite is very interesting. So when you have a patient with respiratory failure, but the lung ultrasound examination doesn't show a pattern suggestive of pneumonia, so a low probability pattern, you can conclude the opposite. So you can conclude that the patient is not a COVID-19 patient, or at least the reason of respiratory failure is not COVID-19 pneumonia. So COVID-19 is not responsible of respiratory failure in these patients, and you should look for the alternative diagnosis in these patients. We are analyzing today, we are finishing to write the paper, our multi-center study on around 1,500 patients that we did involving 22 centers in US and Europe. And we had only one case that was borderline saturation around 93, so what's considered severe phenotype, with negative, or better to say low probability ultrasound, lung ultrasound, but positive PCR. It was only one patient, all the others were negative for PCR. So it is very important, of course, also to give data, to give evidence to what I'm saying, but this is coming, these data are coming very soon. Okay, last topic that I prepared for you, if I have time, I don't know, I think so.
Actually, I think we need, if you could start summing up, I think we do have to move on, unfortunately, even though this has been really wonderful.
Sorry?
So I think that we do have to we have to finish up because we have to,
okay.
We have to move on, but thank you. This has been really, really wonderful.
So I conclude just telling that monitoring is another possibility of lung ultrasound. Very quickly, just to finish, very quickly, there is already a methodology to quantify and monitoring lung ultrasound in our patients that was published years ago in patients with RDS in the ICU. Giving a score to each area with 0, 1, 2, or 3, depending on presence of B-lines, coalescent B-lines, and consolidation. This is the very known methodology that we use. I think in COVID-19, we need something much simpler. And what we are using, and we are trying to validate, is a methodology that gives, in a very quick way, a sort of percentage of distribution of the signs on the chest wall from 0 to 100. And then we have, we make the sum and we divide per 8, the 8 scans, and we have a percentage of distribution of the disease. I think that in COVID-19, this is more working than the old scoring system. Of course, we are collecting data and we will see if it is in agreement with other methodologies for quantifying the damage from COVID-19 pneumonia. Thank you for your attention.
I'm sorry to cut you off. I thought that was a really really wonderful talk. Really, I know helps me in terms of honing in where I need to focus on with my patients. And it was I think a really big treat for us to hear straight from one of our leaders who was really creating the field of lung ultrasound. So thank you, Dr. Volpicelli. This was really a great treat. So we just one quick poll just for the group. So after viewing this talk, I know that I'm feeling so much better about my use of ultrasound. All right, we're just going to take another 10 seconds and then we're going to close our poll. Okay. All right. So I hope that this is a praise to you that we have over 80% of our participants who are either already using ultrasound, or after this talk, we have a good 45%. So at least half of our participants who may or may not have been using lung ultrasound before, who are going to start using it in COVID. And I think that this is going to be, it's a real credit to you and to all of those who are already using lung ultrasound. All right. So we just have a few updates from our president. Just for those of you, this is from our spring conference. You can see everybody in their little Zoom cameras, not what we typically, not the pictures we typically take. For those who are new, I just want to direct your attention to the website, which was organized by our own education director, Dr. Erica Constantine. And the website, you can see the p2network.com. And just again, for those who are new, these are, want to introduce our executive board, Amanda Toney, our communications chair, Dr. Magali Gothe, our finance chair, Dr. Erica Constantine, who I mentioned, who created the website, our education and global health chair, Kathryn Pade, research chair, who you'll hear from in a few minutes, myself, Charisse Kwan, who you will hear from in just a minute, David Tang, our president-elect, and Ron Barant, our immediate past president. So I'm going to stop sharing and let Dr. Charisse Kwan go ahead and give us some updates.
Hi, everyone. Thank you guys all so much for joining. I'm actually quite impressed with the turnout. We, I think at one point hit 158 participants, which is just amazing. And I probably would like to thank Dr. Volpicelli. I think that's the main attraction to our webinar today, to hear from the expert. It's especially important for some of us who have not, luckily have not seen as big of a wave of COVID, and especially in pediatrics, we're not seeing as much of that, but it would be very important to apply a lot of these principles to the few patients that we do see. So thank you again, Dr. Volpicelli. I'm just going to share my screen now. Let me see if I can get that, sorry. Second. Okay. Sorry, just bear with me 1 second. I need to change my system preferences. Okay.
But is that the Cape Town behind you?
That's just a background. I wish I was
yes,
there.
But you know what is the place?
That's South Africa. That's
yes,
Robben Island, actually. Yeah. Did you recognize that? Okay. All right.
I think.
Sorry, go ahead. Okay, all right. So this is just a very quick update. So the first thing I wanted to do is, Stephanie already did this. I just wanted to remind everybody of our great executive team. Ron, who's done a great job over the last couple of years, and Dave, who's actually going to be starting his president role in 2022. And and Stephanie, who's done an amazing job organizing the last webinar, but also this current webinar, and will be continuing to do so in the next year, and all our conference works. Kathryn, who you'll hear from again. Amanda, she's the one who's the go-to person for all our communications. So if you have any announcements to make, please send it straight to her. And Erica, who's not only changed how our education group has functioned, but also created the global health role, sorry. And then Magali, who's really taken on the finances, especially as I'll update you what's going on behind the scenes on the executive level and with our network. So the biggest thing that I wanted to update all our membership on is that we are continuing with our transition to a nonprofit organization. As you know, we've relied heavily on the generosity of Sick Kids for the last, I guess, six years now, I think, with their financial support, but also their administrative support for creating and growing this network. And so now I think we are in the midst of transitioning to a very independent group. And how we've done that, thanks to Ron, our last president, we've enlisted an organization called Paragon, and they organize conferences internationally, but they also can help with all our administrative work, as well as our website administration and webmaster kind of roles. So they'll be taking all of that on, and then they'll be helping us actually grow and develop what we can do as a network as well. With that development, we've actually written bylaws, or Ron has really heavily written the bylaws and gotten us together to approve them. So they will soon be hopefully put on the website for anybody to see, but they've been passed officially by the executive board. And as you know, becoming an incorporation or a nonprofit organization requires kind of annual financial statements, lawyers to be involved, and creation of things like bank accounts in a specific country. So all of that requires, unfortunately, some funding. And so we have talked about this before. We may need to start charging a membership fee, and we will try to keep that as small as possible. But among the executive, we thought that we would probably start charging approximately $100 US, which I think in comparison to many larger organizations is not too large of a fee. And that will hopefully cover kind of this transition to a nonprofit organization, and then fund other activities that I'll talk about in one slide. So with Paragon, I want to introduce our contact with Paragon is Lorraine Lugassi. She also helped organize this webinar, and going forward will help us with a lot of these events. Stephanie mentioned already, if anybody has any questions, wants to check out the website, I want to thank Erica for putting in a lot of work into reorganizing the website and updating it, as well as Veronica Jennings from Sick Kids, who has put in all the work to actually build the website itself. And going forward, we will be transitioning all of this webmaster role to Paragon as well. So if you haven't had a chance to check out, please do. Now, in terms of conferences, our plan is to have 3 webinars in the 2020-2021 year. So hopefully another one in the spring, or well, actually maybe the winter, spring, and then one in the summertime. And then hopefully at some point we will have a live conference again, depending on what happens with COVID. But we definitely want to hear from all our membership about topics you want to hear about, experts that you want to hear from, and any other topics you want to discuss, even in small breakouts. If you have ideas about format and how we can deliver more to you guys. So please email me or email Stephanie, email any of us, whoever you feel comfortable with, and we are happy to try to incorporate all your ideas to make this as useful as possible to you. So what's coming, the webinars, as I've spoken about, hopefully the live conferences will return. What we would like to do in the future is actually start expanding what we do and organize P2-led local workshops in different parts of the world. And they can be, the nice thing about having it as a P2 network is we have such a great wide reach to different sites, but also a wide reach of and repository of experts from all around the world that we can pull from and invite to different parts of the world. And then we've been talking about actually creating our own P2 educational content. Again, because we have access to all these experts from all over the world, we want to hopefully have a bank of lectures or material that anybody can use or reference in the future and keep that updated every few years. That's hopefully something to come and maybe launched on a website, or we're still deciding on platform and how we are going to distribute that to everyone. And there is kind of a global health aspect to this as well. I think it actually came more from the global health side to help distribute information and POCUS related material to areas that have less expertise available to the local communities and where actually may be more impactful, if anything. So that's pretty much it. I want to just open it up to anybody who has any questions for me or for any of the executive board in the next couple minutes, if we have time, Stephanie. If not, we can certainly move on.
And I just wanted to remind everybody that the contact information for the executive team is on the website, just in case you want to reach anybody with any questions. All right, so then we're going to have Kathryn.
Perfect. Welcome, everyone. I'm Kathryn Pade. Stephanie tried to make my name sound fancy. It's just good old Pade. Okay, let me just quickly share my screen. And then we'll just start. Okay, so we're just going to quickly run through some of the research that's going on right now. And the P2 network, a lot of this is on the newsletter, so we're just going to run through it quickly, but we have lots of members doing some amazing things. So Kelly is still running his intussusception study. Congrats to all those that are involved. They're at 90% enrollment, so almost getting there. So just need a few more, and they also submitted an R21 to extend enrollment, and he's working on his manuscript. We still have the POCUS data registry sites available. So Adam's running that. I know he talked about it in our last webinar, but so the registry is active and they're looking for people to participate. So they're not, doing any protected information and images, but it's kind of keep track of POCUS. So if you are interested in using it, just shoot Adam an email, and his email should be on the newsletter as well. And then Sam, again, still, I think he's potentially gotten some people involved in this, so looking at sub-centimeter consolidations. But if you are involved, or if you are interested, please email him, because they're also looking for sites to get involved, looking at sub-centimeter consolidations. And then Sam is currently still working on the pediatric thoracic trauma for POCUS, looking at the lung, and he's looking for sites. I think he got a little delayed with COVID, so please email him if you're interested. And then Danielle is still, she's doing a prospective study to look at POCUS to detect esophageal foreign bodies. They are still in the process of submitting the IRB, but again, are recruiting sites if anyone is interested. And then Charlotte is, again, still looking at the optic nerve sheath diameter. They're currently recruiting patients with a goal of 100 patients recruited per site, and they're actively recruiting. So they have 12 sites currently participating, and of course are looking for more. So if you're interested, please shoot her an email as well. And then David has completed enrollment on his appendicitis study. So congrats to them and everyone that was involved, and currently writing the manuscript with hopeful submission soon. So congrats. And so again, just a quick reminder. So, if any of you are interested in doing a multi-center study and would like to get more studies involved, we can absolutely put you in our newsletter to try and promote some collaboration. If you would like some mentorship on a study, and that way it can then be P2 sponsored, please just shoot me an email as well. We can help with research protocol and any other mentorship or any other questions. So just feel free to contact any of us. And I think that's it, Stephanie.
Okay, I'm just gonna, so we have a couple of announcements. Marjan, are you guys still there?
Hello, good morning.
Go ahead.
Hi, so thank you so much for allowing me a few minutes to talk about this. Nice to see everybody. I'm Marjan Askar and I am at Stanford, and since the last time that we sort of put this on the newsletter with the help of Kathryn, who's been extremely supportive, and also Stephanie, I have heard from quite a few people, and I'm very excited for that. I just wanted to officially go over this again. This is currently in progress. I have right now a total of 4 people that are in addition to us that have expressed interest that we are going to be using the survey to collect data, but we're seeking additional sites for the pilot study of teaching select POCUS applications to pediatric residents. I guess, yeah, thank you. So my email is listed there. Basically, we did a very small pilot study at Stanford with the pediatric residency intern class 2019-2020. And the only POCUS training they had for the year occurred in the PEDS-ED. The response rate was 94%. 21% of the respondents received some POCUS education in medical school. 94% of them were interested in receiving POCUS education in residency curriculum and that it should be required actually. 100% believe that protected POCUS teaching should occur as a part of their residency. And also 100% believe that POCUS is important in their current practice. And a lot, also 81% believe that POCUS is important for their future practice. The people that didn't think it's important were going into genetics, I just have to say. Barriers to POCUS education were that they had no established curriculum and there was lack of knowledge of and experience of the faculty. And basically, the next step in this, and I've done a lot of work, legwork for this. And so the next step for this is that once we get our multi-center sites that are involved, we are going to form a POCUS subgroup within the curriculum learning community at the Association for Pediatric Program Director, which I just actually finished completing and will be chairing. And it's really important to get into the APPD, because if we're hoping for any curriculum change, that is where we need to be. It's not the AAP, it's the APPD, the Associate Pediatric Program Directors. Basically, what I would really love to advocate is POCUS specific curriculum development and faculty education. And something that we are sort of launching here at Stanford, and I'm very interested in, is that we can offer the community pediatric residency program, tele-ultrasound education, which we've done a couple of studies on the method of tele-ultrasound training. And so stay tuned for that. That's going to be coming out soon. And I could put it in the newsletter as to where you could look for it. And then the most important thing for me really is to recognize the P2 efforts to make this collaboration possible, because without this group, I would not have a study. And without a study, I sort of would be still running around. Shortly before our last meeting, I didn't know where to go, who to talk to, and I just connected through P2, and I feel much more optimistic in this journey. So I just want to appreciate everybody listening, and if you're interested, please reach out. For interested people, I will go ahead and obviously share the REDCap survey link, and if you guys want to talk about more specifics, please reach out. Thank you so much for having me.
Thank you, Marjan.
Thank you.
All right, and then Lily.
Hello. I didn't realize I was going to get a little video time. Thanks also for giving me a minute. I wanted to talk about the POCUS Toolbox project, where we're working on assembling curricula, and we're mostly interested now in practice physicians. We talk a lot about how we train residents and how we train fellows, but we don't talk as much about how we train those who are already in practice. Of course, P2N and many other, and the AAP and higher up organizations, we have nice recommendations for how to put together such a curriculum, but we don't have a repository of real world examples of what these look like. So as now someone who finished fellowship and is in a community hospital, I'm curious to represent a really diverse array of places, from children's hospitals, but also to community hospitals who see children. So if you have such a curriculum, or you've been meaning to write one, I'll encourage you to send it to us. And we're working on figuring out what sort of method we're going to put these together, some sort of website or different thing. And this is in combination with ASEP ultrasound section. Of course, we're also looking for team members to join us. And here's our team: Lorraine, Atim, Matthew Kusulas, and Henry Chikaisa as our main team right now. Thank you very much.
Thank you so much, Lily. And somebody had asked about emails. We'll try to get that up in the chat by the end, and if not, they will be on the newsletters and on the website. And lastly, we have Kayeta.
Hello. I just wanted to give everybody an update. So we have been working on the pediatric focus assessment tool for several years. A large group of people helped with the nominal group and the modified Delphi. Last year, we offered the first assessment, trying to get enough data so that we can have validity with reliability and generalizability, but we needed more. And this year it got delayed because of COVID. And so what we're looking for is the POCUS directors to register your PEM fellows and encourage participation. There will be information coming out in the newsletter, so just look for it specifically. But if you are at a PEM, have a PEM fellowship program, POCUS director there, the lead, and you have a longitudinal POCUS curriculum, then your PEM fellows are eligible to participate. We still don't have the data to have a cut score or a passing score yet, but we will send you the information on your individual fellows once the testing is complete. And hopefully after this round, we'll have enough information to make this test available more globally for the intended purpose of the graduating third year PEM fellows. So if you have more information, you can check out the newsletter coming or contact me. We should start offering it in December of this year. Thank you.
All right, thank you so much, Kayeta. And I think this will hopefully, once we can get those scores, will be really helpful. This is a space saver slide, which unfortunately we actually are running 5 minutes behind, so I'm not going to be right back. But we have another QR code here. So if you haven't had a chance to access the survey, you can just take a second and shoot your camera right up there, and you can get the survey. All right, I'll give that just another couple of seconds, and then we're going to move on to our cool cases. So we have, we've selected several, we elicited submissions from within the network, without the network, of people. We wanted to see what everybody was doing and how you were using ultrasound and some of the interesting ways you were using it to manage your patients and help with improving their care. These cases were selected anonymously by our executive board, and we have 7 great cases that I think you'll really enjoy. So I first want to introduce Dr. Zoe Grabinski. Dr. Grabinski is a third-year pediatric emergency medicine fellow at Columbia University Medical Center, where she also completed her pediatric residency. Dr. Grabinski, if you just want to share your slides.
Hi, everyone. Thanks for having me. I am going to share my slides now. Okay. This is a case of a stab wound to the buttock. So this patient was brought in by EMS with a stab wound to his left buttock. His vital signs were unremarkable, as shown here. His initial primary survey revealed an intact ABCs, a GCS of 15, and on exposure, a 2-centimeter entry wound to the left buttock, which was oozing blood. His secondary survey revealed no other injuries. And on this slide, I have a photo of his wound. And you can see here there is about a 2-centimeter entry wound, the laceration to his left buttock. The patient stated he did not know the weapon that was used, and the wound was probed by the surgical team in our trauma bay, and no end of the tract was identified, but it did not appear to invade the rectum. We applied a pressure dressing to the wound with sterile gauze and completed his evaluation, which included a primary survey FAST, which we completed. So this is the initial transverse pelvic cliff, and we can see here a well-circumscribed structure with mixed exogenicity. We believe this was the bladder filled with what we believe to be blood and clots. The remainder of the FAST was negative, and there was no evidence of free fluid posterior to the bladder or in any of the other FAST views, which I don't have to show here. And anyone, please feel free to stop me if you'd like me to stay on some of these clips for longer. So the patient then began to complain of the urge to urinate, and he developed blood and clots flowing from his urethra. We immediately called urology, who arrived to the ER and placed a 20 French hematuria catheter. Immediately, about 1 liter of blood and clots were evacuated in that catheter. So we proceeded to bring him to the CT scanner, at which time we obtained a CT and a CT angiogram of his abdomen and pelvis. The CT revealed an active bleed within and adjacent to the left posterior bladder wall. And we also were able to see a clot-filled bladder and a pelvic hematoma, which displaced the rectum. We obtained then after a CT cystogram, which showed actually no extravasation of contrast to suggest there to be a bladder rupture. And here's just a quick slice of that CT angiogram. And we can see here this deep pelvic hematoma, which displaces the rectum. And we see the bladder here filled with this dense fluid and debris with non-dependent and scattered air. The bleed is not shown in this slice here. So from the CT scanner, we brought him back to the trauma bay, which is just across the hall. And we gave him 2 units of PRBCs as he was continuing to have blood and clots from the hematuria catheter. We knew there to be a bleed, and it was difficult to estimate the quantity of blood that was lost. Urology then began to copiously irrigate the bladder to remove the clots. And at this time, he then developed some significant abdominal pain. His abdomen remained soft, non-distended, and he had no peritoneal signs, and he had no change in his vital signs. However, because of the now new development of abdominal pain, we repeated our primary survey and our FAST exam. And so here is the repeat FAST exam after the development of abdominal pain. And so we can see here first in this right upper quadrant view, we see the superior pole of the kidney. We can see the tip of the liver here. And we can see this anechoic area, which I'm attempting to highlight with my mouse, which is indicative of fluid here in Morrison's pouch. And so this is now the development of a positive FAST. Here we have the left upper quadrant view, and this view shows above the diaphragm here, the inferior pole of the kidney, and then we can see the spleen, which is surrounded by fluid as well. So this is a trans view of the pelvis, and we can see again a well-circumscribed structure, which we believe to be the bladder, filled with hematoma appearing as this mixed echogenicity. There's also free fluid we can see behind the bladder, posterior and lateral. We can also see a Foley balloon within the bladder, which appears quickly and then disappears quickly. And we can also see this enhanced peritoneal stripe sign, which I will show again as a still clip on the next slide. This is just a still from that prior clip showing this echogenic stripe signifying free peritoneal air. This is also called an enhanced peritoneal stripe sign, or EPSS. This is now a long view of the pelvis. And again, we can see the bladder filled with blood and free fluid, and we can see this posterior and lateral to the bladder again. Free fluid coming in and out of this clip, and we can see this EPSS sign as well. This clip actually shows the bladder while being irrigated with saline by urology. This large amount of free pelvic fluid is now also seen posterior and lateral to the bladder. And this raised the question to us of whether this is irrigation fluid in his peritoneum or if this is free intraperitoneal blood. We also do know that there was free air as well from the EPSS sign. So our patient was transported for IR angiography and exploration and possible embolization of the spleen. General surgery and urology were also present in preparation to convert to a diagnostic laparoscopy if needed. So when IR went through with their angiography, they actually found no active bleeding vessel. So it was thought that perhaps what was seen on the CTA had clotted off prior to them going in. So the patient was converted to a diagnostic laparoscopy with general surgery, the trauma team, where they found this full thickness injury to the bladder at the dome, not seen on our CT cystogram, and they found a large amount of irrigation fluid in the abdomen. Urology then came in and they completed the operation, finding 2 full thickness bladder injuries. They estimated a 1.6 cm left inferior lateral laceration and a 0.6 cm laceration at the dome. So a through and through bladder wall injury. This is a picture taken in the OR of the bladder of this inferior laceration, and the DeBakey here indicated the left ureteral orifice, so how close this wound is to that ureter. So on follow-up, so the patient's defects were repaired surgically and a left ureteral stent was placed. He's actually discharged home on post-op day 4 with a Foley still in place. And he underwent a successful trial of void 1 week later, or 1 week actually after the operation, which was successful and his Foley was removed. So we thought this was an interesting and illustrative case of the importance of repeating a FAST exam when there's any change in the patient condition, as you would your primary survey. In this case, it was the development of abdominal pain that prompted us to repeat his primary survey and FAST, despite the stable and normal vital signs that he had. This new finding of free fluid and free air allowed for improved operative planning with interventional radiology, surgery, and urology, that he was able to have this seamless conversion to a diagnostic and definitive laparoscopy by urology for repair of hip injuries. Thank you all so much for allowing me to present.
Thank you, Zoe, for presenting that really great case. I know, and hopefully you'll identify stuff. I know I've received a questionnaire or survey about serial FAST exams. I know somebody in the group is doing a research project on this. And so definitely please share that with us. Just one question. Why did the team think that the cystogram was normal if with these large lacerations?
Oh, so we actually really are not sure why the cystogram was normal. It was thought that there was a difficult discussion on whether or not to obtain a CT angiogram first, knowing that possibly the contrast that we gave for the CT angiogram might have obscured some of the images of the CT cystogram, but we felt that the risk of an intraperitoneal bleed and the complications that would come from that took priority to identify before obtaining the CT cystogram. The CT cystogram was definitively normal by radiologist Reed and by the urologist, who actually were the ones that pushed the contrast for the cystogram in the scanner. So possibly from the contrast we gave, maybe those images were not fully illustrative of the injuries.
Really great case. So our next presenter is going to be Dr. Lauren Silame. Am I saying that right?
It's Salami, very close there.
Thank you. Salami. I'm going to work on my pronunciations of names today.
It's a very hard one.
Dr. Salami is completing her emergency ultrasound fellowship at the Massachusetts General Hospital. She received her medical degree and completed her residency in emergency medicine at Thomas Jefferson University.
Thank you. So I'll be presenting today a 3-month-old female with tachypnea. So getting right to it with our case presentation. A 3-month-old female, a prior full-term baby with no past medical history or recent illnesses, is brought to the emergency department after she awoke her mother at 3 a.m. due to tachypnea and cough. They went to an outside hospital first, where she was febrile to 101.5. She was a bit tachypnic at 60 with noted nasal flaring and retractions, and she was satting 98% on room air. A chest x-ray was read as worrisome for pneumonia. She was treated with nasal suctioning, given an antipyretic, and given IV ceftriaxone. Promptly, she was then transferred to your emergency department. Here, an x-ray was done, which shows an enlarged cardiothymic silhouette, and we can barely see the left lung, just a little bit over here. An EKG is done. It shows sinus tachycardia, also some LVH, as we see that the QRSs are totally touching, and there's T-wave inversions laterally. As an astute clinician, you use one extra tool. So you do a cardiac focus, and immediately, I think most of us can see that, uh-oh, this heart is barely moving. There's a decreased EF, and the LV is severely dilated. On the upper left, we can see an apical 4 chamber view. Then we see a peristernal long axis on the right, and then a short axis and a subxiphoid at the bottom. You can also notice some B lines along the posterior pericardium, which would be consistent with likely signs of pulmonary edema or backup from the heart. So this now seems a lot more consistent with a dilated cardiomyopathy, much different from the pneumonia patient that you just got transferred. So thinking about the differential diagnosis for this patient, the most common in infants is viral myocarditis, but other etiologies include ischemic cardiomyopathy, genetic cardiomyopathy, idiopathic, chemotherapy exposure, and metabolic disease. For treatment and workup, milrinone is promptly started for the ionotropic effects, and some labs come back. A VBG shows no acidosis, white count and CRP are just barely elevated, and a high sensitivity troponin and BNP are both very high. A comprehensive echo is then ordered, and it shows anomalous left coronary artery from pulmonary artery, or L-kalpa. So we can see that the left coronary artery is actually coming off the pulmonary artery in this diagram. It's giving way to the left anterior descending artery and the lateral circumflex artery. So looking closer at the POCUS that we had initially. Here we have the peristernal long axis view. On the left is diastole, and on the right is systole. We know this because the mitral valve is open in diastole. This is actually as much as this heart had the valve open, and in systole, it is closed. This can tell us that there is a severely decreased EF, just that the mitral valve is barely moving. And next we look at the LV free wall. So right here in blue. It should thicken during contraction, but in this heart, it's barely thickening. or maybe not even at all. So this is a sign of lack of fractional shortening. We also see a dilated LV. And although not really appreciated in this image, in L Kalpa, you can also see a dilated LA. And you can look in the 4-chamber view for signs of mitral regurgitation. Next, looking at our short axis views, these were a little bit limited, but we can again see a poorly contracting heart. And we can look closer at which area specifically is not contracting. So we'll look for regional wall motion abnormalities. I think it seems like this bottom left, the posterior septal area really is the only area that is moving in this heart. So we'll go through a diagram of the vessels that serve each area as seen on the short axis. So in blue on top, we have the LAD, which serves the anterior septal area. And then in yellow, we have the lateral circumflex serving the lateral area. And in red is the RCA, which will be the only oxygenated vessel in this L Kalpa patient. It serves the posterior septal area. And again, in the clips we saw, this really was the only area that seemed to be moving, the only area that wasn't served by the pulmonary artery. In L Kalpa, we can also classically see echo-bright papillary muscles. And going through kind of the key takeaways from this case, L Kalpa it's a very rare form of ischemic congenital heart disease. It's only 1 in 300,000 children, but it accounts for 0.5% of congenital heart disease. It frequently presents in the first year of life with signs of kind of heart failure. It is diagnosed with a comprehensive echo and possibly cardiac catheterization if the echo is inconclusive. But without your own clinical gestalt and your suspicion, you may actually miss this. So POCUS really helped in making this diagnosis. The ultimate treatment is surgical repair. Without that, there's a 90% mortality rate, and this child did go on to having it repaired and is still doing well today. So I wanted to thank the ultrasound division at the Massachusetts General Hospital, and specifically Dr. Sigmund Karish for his support and guidance in creation of this work. Thank you, everyone.
Thank you, Lauren. That was a really great case, and I think that shows again why we do, why we perform POCUS. And I really like how you focus on the wall motion abnormalities, because generally in POCUS we don't look at the coronary vessels, and I think this is really demonstrates how our POCUS exam can help narrow down that differential. Our next presenter is going to be Dr. Jason Gillen, classic pronunciation. Dr. Gillen completed his residency in pediatrics at the Johns Hopkins Hospital in Baltimore before completing fellowship in pediatric emergency medicine at the University of Texas at Austin. Dr. Gillen is currently a POCUS fellow and an assistant professor of pediatrics at Emory University School of Medicine, and I am proud to say that he is my fellow.
Thanks for that intro, Stephanie. Let me just share this and get going. All right, I have a case for you guys of a 12-month-old male with a clouded cornea. This is the picture of the actual patient. The mother did get permission to use this photo for this presentation. And this is a case of a 12-month-old male who comes in with a 1-day history of left corneal clouding without really any other symptoms. Mom said he was fine the day before. Woke up that day, noted that his left eye looked cloudy, and so brought him in for further evaluation. For his physical exam, it was just noted, as you can see in this image, that his entire left cornea was opacified, not reactive to light. His contralateral eye, his right eye, was normal grossly. And so we ultrasounded his eye, and I'll just play this clip for you guys a couple times through. Here are a couple still images from that clip that was done in transverse, just fanning through the eye. And as you can see here, there's a pretty large heterogeneous mass that pushes on the anterior chamber of the eye, which is better appreciated in this left-hand image where you can catch the posterior lens here. What you can also appreciate on this, on really both images, but on this left one, some clean posterior shadowing through the retina that would be consistent with shadowing from a calcification. You can see a little hyperechoic area right here on this left-hand image. And so the clinical course for this patient, we obviously had the ophthalmologist come in and evaluate him bedside. He had elevated intraocular pressure of his left eye, quite high at 47 compared to 19 on his right eye. He was started on some eye drops to decrease his pressure, and the ophthalmologist agreed that our bedside images were concerning for retinoblastoma. And so this patient was admitted and had an exam under anesthesia and an MRI the following morning. He actually had bilateral retinoblastoma, left worse than right. We did not image the right eye at the time. And his MRI demonstrated tumor extension into his optic nerves in both eyes, but there was no intracranial mass present. And so this patient was admitted to oncology for some systemic chemotherapy, which is kind of the management of choice if you have bilateral retinoblastoma, in order to save vision. If there's just extensive disease in one eye, usually enucleation is a treatment of choice for that case. But because it was bilateral, they started with systemic chemotherapy first. And just to show you guys the MRI for comparison, so you can see that our ultrasound image here really did demonstrate the contours of the tumor mass quite nicely compared to MRI. On this right-hand image, you can see that there is a smaller mass in the right eye that we most likely would have seen had we ultrasounded that eye. And in MRIs for both T1 and T2 weighted images, calcifications appear dark, and you can see that this larger calcification here corresponds nicely to the calcification we picked up with that posterior shadowing through the retina. And also on this right-hand image, you can start to catch the tumor extension into the optic nerve that was better visualized on the left eye with a more extensive disease. And so the main learning points for this case, for ocular ultrasound, it's a great application for kids of this age who are not going to be compliant with a fundoscopic exam or needing to keep their eye open. No sedation was required. We were able to complete this exam in about 20 seconds, fast, no radiation involved. For retinoblastoma itself, it is bilateral in 1/3 of cases. So if ever evaluating for this, make sure to check both eyes, which is something I'll remember for next time. Calcifications are pretty much the hallmark of retinoblastoma on your differential for intraocular masses in children of this age. And they're present 95% of the time. It can help distinguish between other types like hamartomas, for example. Your principal presenting complaint will be leukocoria. Actually, for this patient, when we reviewed some of the images on mom's cell phone of the kid, you could appreciate some leukocoria in his left eye from some recent prior photos. Your second most common presenting symptom will be strabismus, with corneal clouding and glaucoma being much rarer presentations. And that is all I have for you guys.
Can I ask a question?
Please.
Sure, go.
Hi, Jason. You did an amazing job.
Hey, Marla.
So nice to see
Thanks.
you. How did you get this little one to cooperate with your ocular ultrasound?
There was no cooperation involved. We just kind of held him down briefly with the tech, put a tegaderm over his eye, and really had the whole ultrasound done within 20 seconds. So it was quick, probably uncomfortable for him, but it was very quickly done.
I think it was my charm. He didn't cry at all. He really didn't. We put him in his mom's lap and she hugged him and he did great.
Wonderful. That's great. Great, absolutely beautiful case.
All right. Thank you, Jason. All right. So our next presenter is going to be Natasha Cabrera. Tasha is currently a first-year Penn Fellow at Children's Hospital Colorado. She completed a pediatric residency at Children's Hospital Colorado and is interested in POCUS research in managing sepsis.
All right, and I'll go ahead and share my screen now. All right, so this is about a 5-year-old male who presented with abdominal trauma. So this is a previously healthy 5-year-old male. He came in with acute onset abdominal pain with nausea and vomiting. The story was pretty benign. It sounds like he was playing with 3 of his friends at school and got pushed into the other one accidentally, hit his stomach on the side of the other kid, and then automatically started vomiting. Parents came to school to pick him up pretty soon thereafter and said that he was vomiting about every 15 minutes and seemed to be in exquisite pain. They brought him to his PCP where he got some Zofran and then was referred to the ED for further care. On exam, other than a mildly elevated blood pressure, his vital signs were otherwise normal. Looking at him in his bed, he seemed pretty uncomfortable. He was fidgeting around trying to get comfortable without any success. His cardiac and pulmonary exam were normal. And then his abdomen appeared flat. There wasn't any external signs of trauma. His bowel sounds were normal. On palpation of his abdomen, I didn't feel any masses, but honestly, I couldn't palpate the left upper and lower quadrant much because he had so much guarding on exam. He also had some left CVA tenderness and a positive heel tap. On GU, he had a normal appearing testes and penis. And with this exam, I was pretty concerned about him. You know, when I was walking into the room and heard this story, I thought the story didn't really fit with this presentation with how frequently he was vomiting. And I had a pretty broad differential in mind, thinking about could this be anything from non-accidental trauma with a renal laceration to maybe some renal colic or nephrolithiasis. But after getting this exam, I was pretty concerned, so I decided to do a point-of-care ultrasound. We'll go through his right upper quadrant and left upper quadrant views. His substernal and his pelvic ultrasound were unremarkable. So going through his right upper quadrant, you can see the liver tip is caught, and there's a very subtle trace amount of fluid just at the tip of the liver. Otherwise, it looks normal from an academic perspective. You can also see sweeping through the kidney that it looks grossly normal. So just maybe some slight free fluid right at that tip that we kind of just scroll through. And moving on to his left ultrasound. At first, looking at the splenic tip, I was having a hard time saying whether or not that was free fluid right there. I wasn't able to get any better images due to pain and patient intolerance, but going through that left side, you can see where the kidney should be. There seems to be this very irregular mass with a nice capsule. And in some areas, it looks like maybe there's some regular kidney architecture, but overall grossly effaced with a large mass. This is another video just going down a little bit further, kind of scrolling through it completely. We're kind of seeing that circumferential mass where the kidney should be. Focus interpretation. So I was definitely concerned about possibly there being some intra-abdominal free fluid. There was definitely loss of architecture of the left kidney with concern for renal mass. As soon as I stepped outside of the room, I texted our POCUS guru, Megan Mickley, and I was like, this kidney looks abnormal. It looks like there's a mass. And for reference, this is my first introduction to POCUS. So I've only been doing it for about past 5 months now. And immediately Megan's response was, is this a Wilms? And I was like, that's what I was thinking. And I hadn't even told her the age or anything. So a lot of support in our household, which is great. And then this patient ultimately ended up getting a CT diagnosis after we consulted urology and hematology oncology. His CT was impressive. He had a large heterogeneous mass. On that left side that centered within the kidney, it was most concerning for a Wilms tumor, which is what we were thinking. And then there is evidence of fluid and inflammation within the surrounding fat and extending along the left paracolic gutter, concerning for tumor rupture. Oops. So learning points, always evaluate the normal side for comparison. I put normal in quotations because this patient ended up having bilateral involvement of his kidneys. The right side was very small and I was unable to see that on ultrasound evaluation. Always keep your differential broad. I didn't go into this thinking that this was a Wilms tumor, but as soon as I saw that image, I was definitely concerned for that. And then once your suspicion for a tumor arises, try to minimize interventions that may increase risk for capsule rupture. So this isn't a patient that I'd send medical students in on to go do a physical exam just because you're really concerned about that capsule being thin and having that rupture, which then increases your tumor grade. And after we were concerned about tumor, this patient didn't have any more exams for the most part. And then POCUS is fun. That's all I've got. Thank you, everyone.
Thank you so much, Tasha. That was a really great case. Just one thing also that I've noticed over the years is, you know, when you have a patient who comes in with what seems like a minor trauma, but has, you know, pain out of proportion, that's something that POCUS is really helpful for evaluating further. Okay. Our next presenter is going to be Dr. Kristen McLeod, and I hope I'm saying that right. Dr. McLeod is an emergency medicine resident at Denver Health. She completed medical school at the Mayo Clinic, Alex School of Medicine.
All right, thanks. Yes, very close is Kristen McLeod. So I'm going to present a case today of a 17-year-old female with hemorrhage and syncope. I saw this in the Denver Health Pediatric Emergency Department with Dr. Meggett. Let's get started. So this is a 17-year-old female. She has a past medical history of anorexia nervosa that had been complicated by bradycardia, chronic anemia, and amenorrhea. And the story is she was found at home after a syncopal episode by a toilet full of blood. They thought it was likely menstrual in origin. She didn't have any other, no major other associated symptoms. She had some fatigue and lightheadedness, but no chest pain or shortness of breath. She didn't report any melena or GI bleeding at this time. She said she'd never been sexually active. She's been having irregular periods over the last year, kind of in association with her anorexia. And she thinks maybe her last menstrual period was about 4 months ago. But otherwise, she had had no history of similar bleeding episodes, vaginal, GI, or otherwise. On physical exam, she was pale and diaphoretic. She was extremely fatigued and nearly required assistance to even move around her bed. Her heart rate was high normal while she was laying there, but even with slight movements, she would get tachycardic to the 110s, 120s. On EMS transport, they initially found her blood pressure to be 80 over palp. They gave her a liter of fluids on her way to the hospital, and her blood pressure, by the time she had gotten to us, had improved to kind of systolics in the 90s to 100s. Her exam was otherwise pretty unremarkable. Up front, heart and lungs normal, and her abdomen was completely soft, non-tender, non-distended. So at this point, we wanted to get our ultrasound out to kind of help us in determining what the underlying etiology might be, though we had some ideas. And initially, her heart had good function. Her IVC was collapsible. There was no free fluid in her left or right upper quadrants. But when we got to the pelvic view, this is what we saw. Here's a kind of representative image. So we see the bladder up anteriorly, and that appeared to be intact. And just below, we see the uterus, which appeared to have an abnormal structure. On kind of bedside interpretation, we thought possibly uterine didelphys or a bicornate uterus. And then within the uterus itself, we see this anechoic collection of fluid we presume to be blood, as well as some more hyperechoic collections that we thought could be either tissue or more clotted blood. And armed with this new information and a likely source of her bleeding, we proceeded to do a pelvic exam where there were multiple large clots that were evacuated from the vaginal vault. We didn't see active bleeding at the time, but she did have duplicated cervices and no vaginal septum, as can sometimes be seen in these abnormalities. Her labs were starting to come back at this time, and she was not pregnant. Her hemoglobin was significantly decreased to 7.6. About 1 month prior, she had been at 11.8 for a hemoglobin. We did get a consultative transvaginal ultrasound, which showed pretty similar findings to our POCUS evaluation. She had completely duplicated uterine cavities and duplicated cervices as well, which is consistent with a uterine didelphys morphology. At this point, we proceeded to transfuse 2 units of blood for her hemodynamic instability and initiated an OCP taper. She was admitted overnight for observation, kind of out of abundance of caution, given her anorexia and wanting to monitor for any fluid shifts or electrolyte derangements. And she had a very uneventful stay in the hospital and was discharged home with PCP and gynecology follow-up. Kind of our final clinical impression on this case was that she had ovulatory dysfunction, likely from her anorexia. And given this uterine didelphys morphology, she had kind of increased endometrial surface area. And as she was refeeding and reinitiating menstruation, that allowed her to have some hemodynamically significant bleeding. So just a couple conclusions and pearls as well. In summary, POCUS, and especially the rush exam specifically, helped us rule out some life-threatening causes of shock in her, but more importantly, ruled in uterine bleeding and kind of cinched that possible and likely source of hemorrhage in this patient. And we'd encourage everyone to do early rush exams, early and often in your hypotensive pediatric patients to guide resuscitation, to guide your resuscitation efforts, essentially. So. And here are a couple references. And I just want to thank Dr. Tony and Dr. Megget for their help in preparing these slides as well.
Thank you so much, Kristen. I really enjoyed that case. I loved seeing those images. They are very cool. All right, sorry, we're almost through. We might go just a few minutes over, so I really thank you so much for joining us today. I'm sorry about the time management. I want to introduce our next presenter, Dr. Eric Shire. Dr. Shire is an alumnus of the University of Maryland and Emory University, and is currently an attending physician at the Kaplan Medical Center Pediatric Emergency Department in Rehovot, Israel.
Mute. I'm unmuted. All right. And now I am sharing my screen. Thank you all for having me. This presentation is titled, Please Treat This Dental Abscess. I will fly through this in the interest of time. I'm Eric Shire, and I am a POCUS super user, which means that I do it a lot. I'm not formally trained, but when my fellows or residents say, hey, I think this kid needs a scan, I say super. So that was my joke for the day. Let's move on. Okay. So please treat this dental abscess. I have to move this out of the way. I actually cannot see my own slides. Okay, I'm not so good with Zoom. So this is a 9-year-old boy who presented with 2 weeks of swelling to the left maxilla. And he went from his PMD to a dentist. The dentist gave him Augmentin. He had a course of Augmentin for about 10 days. It wasn't getting better. 3 days before he came in, he started to complain of visual change to the left eye. So they sent him to an ophthalmologist, and the ophthalmologist noted impaired abduction on the left and a swollen left fundus. So this kid is now coming in with a dental abscess that just won't resolve, and visual changes with findings on his optical exam. So when he walked in, I mean, from the door, he actually did look like a dental abscess. He had this swelling over the left maxilla. When we actually examined it, it was without fluctuance or erythema, and it was mildly tender. His proptosis and impaired abduction were difficult to appreciate. From the door, again, he looked like a dental abscess. He had labs that were grossly normal. And then we'll talk about the focus of left maxilla in just a second. I also did a screen of his abdomen using fast windows, which didn't find any effusions or any abnormalities. And then we did an ocular focus, which showed swelling of the optic disc. Well, I'll show you that in just a second. But what was interesting was that he had optic disc swelling without widening of the nerve. So here's the picture that what we see here. You can see kind of the line of the mandible of the maxilla here. We've got the masseter overlying it, and then you've got this mass. And so the question is, what is this? Is this a node? Is this a dental abscess? And just a few things off the bat that suggested that this was not a node. Number one, it's not in an area where we see lymphadenopathy, and there are no surrounding nodes. Number two, a healthy node has a defined mediastinum running down the center. And this, while you can maybe see a mediastinum here, this had a number of echogenic striations that were very similar to his masseter. This actually looks like a piece of meat, as does the masseter. And I'll show you color in just a second. A node has a central vasculature running into it that then branches in a tree-like pattern, and that was not present here. And it also, as we'll see in just a second, had an extension. It ran deep to the bone, and so when we turned our probe obliquely, you can see that he has fluid collections in the center of this mass, and that it does run deep to the bone. put some color on it. This is not the best picture. I could have centered the Doppler a little bit better, but he's got some kind of random flow into it. We've got vasculature supplying this mass, but there is no characteristic branching pattern suggesting that this is a node. His eye, you can see the elevated fundus here and a bit of the nerve shadowing, and just kind of gestalt is that this is not a widened node, and when we measured it, it was indeed within normal limits. He went for CT, and you can see that the CT image is actually very similar to our ultrasound image. This is that mass we saw on the first slide, and with a central fluid cell collection that we saw on the second slide, and does run deep into it, actually filled the sinuses and retroorbital area, which was what was placing pressure on his nerve, creating that elevated disc. He did have rhabdomyosarcoma on pathology. He actually just went for chemo today. He's doing great. So this is a dental abscess on POCUS. I took this from a paper that was out about 10 years ago. And what they found were images that were actually kind of similar to what we saw on the second, my second POCUS slide, with these areas of hypoepigenic fluid filling the abscess cavity. Here they find, again, fluid, but this abscess photo is without that characteristic muscular mixed echogenicity that you see on my first POCUS slide. And here, this also from a presentation, this was from a case presentation online, because there really is no literature on finding dental abscesses on POCUS, which is kind of an interesting thought, maybe something that somebody might want to explore. But this is also an image showing the hypoepigenic abscess overlying the periapical region. So in summary, I guess my question was here, why did he have to circle the parking lot for 25 minutes looking for parking to come to an emergency room for the scan? What value did I add in the emergency room? He was headed in the end for definitive imaging, and I guess my first takeaway here is POCUS first, even in outpatient setting. I think that we are coming up on an era when handheld ultrasound will be accessible enough for many practitioners in an outpatient setting, and perhaps we can find these abnormalities, these pathologies earlier, and positively affect prognosis. POCUS first, even if you're not an expert, which I am not. In order to find pathology, I've just done a lot of screens in order to learn normal. I know what a normal node looks like. And so I was able to say that this was not a normal node. POCUS is a screening tool, and it can be very helpful, even if only to send them for definitive imaging, to say that this is, I don't know what this is, and that this is not normal. And thank you very much.
Thanks, Eric. I thought that was a really great case, especially just, you say you're not an expert, but being able to differentiate between an abscess, a lymph node, and a muscular structure, I think, really shows the benefit of being able to do POCUS and, during your physical exam, being able to get those findings quickly, and it can really help direct your management. All right, and our last presenter, and thank you guys for bearing with me, is Dr. Omar Damji. Dr. Damji, and I hope I'm saying that right, is a resident in the Calgary Emergency Medicine Program and a fellow in Pediatric Emergency Medicine, and he completed his medical training at the University of Calgary.
Awesome, thanks for having me. I'll just share my screen. Great. Awesome, thanks everyone for having me. I'd like to present a case of a 7-year-old boy who presented with a murmur, and I saw this case with Dr. Williman, Dr. Bromley, and Dr. Lamb at the Alberta Children's Hospital. And so this is a 7-year-old boy who was otherwise healthy, who moved from Somalia about a year ago to Canada, took no medications, he was fully immunized, and had no allergies. He presented with a 2-week history of nocturnal fever, malaise, fatigue, and shortness of breath on exertion. Prior to this symptomatology, he had a cough and a runny nose. And 3 days prior to his emergency department visit, he had some significant shortness of breath on exertion and also just with drinking water and taking a few steps at home. He was seen by a community pediatrician and sent in under the presumptive diagnosis of myocarditis. And so when we saw him, his vitals were relatively normal. His temp was 37.9 after antipyretic therapy, and he was mildly tachypnic and on room air. Otherwise looked well hydrated, did have an elevated JVP, had a 3 out of 6 holosystolic murmur at his left lower sternal border, and did have hepatomegaly with his liver edge 5 centimeters below his costal margin. His abdominal exam was otherwise unremarkable. His ECG was also otherwise unremarkable. And so at this point, in the case of the murmur, we decided to take out the ultrasound machine and take a quick peek. So as you can see here, this is a parasternal long view of his heart. Overall, we can say that the contractility of the heart is otherwise normal. But what we can see here is that there is a little bit of irregularity to one of the leaflets of the tricuspid valve, and there is some sort of irregularity at the basal aspect of the septum there. And this is a still image just showing that. So here we've got kind of thickening of that valve and kind of holes within the basal septum. There are some anechoic areas to the septum. Our next image, we decided to put Doppler over top of the valve. So the mitral valve, as you can see here, there isn't any jet through that valve or regurgitation in an otherwise normal contracting LV. And we decided to move the Doppler over. And as you can see here, there's quite a bit of regurgitation and a focal jet through the basal aspect of the septum there, indicating that this might be a basal VSD that was otherwise undiagnosed for him. And this is a still image showing that jet. This is an apical 4-chamber view without any sort of Doppler on it. And if I can bring your attention to the right side of the heart, you can see here that one of the leaflets of the tricuspid valve looks thickened, and there seems to be something that's flowing within the RV cavity. And given his clinical presentation and now a diagnosis of a VSD on ultrasound, with his fever, we were thinking tricuspid endocarditis. And if we put Doppler over top of that, we can see some focal jet through the tricuspid valve, and that may just be shrouding from the tricuspid endocarditis. And to confirm a degree of Doppler flow and some right-sided heart pathology, we decided to do an IVC view. And as you can see here, when we put Doppler over top of the IVC, we can see some Doppler flow into the IVC at the entrance of the RA, as well as some Doppler through the hepatic veins, which indicates in this circumstance, at least mild to moderate tricuspid regurgitation. And so overall with these images, we were led with the presumptive diagnosis of an undiagnosed VSD as the nidus for his tricuspid endocarditis. And at this point in time, we were able to start him on antibiotics and obtain the appropriate cultures for endocarditis and referral to cardiology, as well as teams for admission here at the Alberta Children's Hospital. He did get a formal echocardiography the following day, which showed a 1.5 centimeter mass at one of his tricuspid valves and a perimembranous VSD. He did receive 6 weeks of antibiotics and then was transferred to Edmonton, our cardiac center here in Alberta, and had a perimembranous VSD closure as well as tricuspid valve reconstruction. Following that, he was on antibiotics for another 4 weeks. And unfortunately, post-operatively did develop some pericarditis after that, but is otherwise recovered and doing well. So I hope to leave you with 2 teaching points or 2 learning points. The use of color Doppler to evaluate blood flow when the IVC is full can help to determine the degree of TR. And if you see something there, at least may indicate mild to moderate TR. And in the presence of a murmur on physical exam, it's really important to evaluate all valves with ultrasound if you're able to do that. Thanks everyone for your time.
Thank you so much, Omar. I thought that was a really great case. And, you know, I know we do a lot of POCUS, especially with kids, you know, when they present with heart failure symptoms. And I think that really focusing, you know, when you're not seeing any signs of heart failure, really looking at the rest of the anatomy, the interventricular septum, the valves, and using Doppler to help, you know, to elucidate these findings is really helpful. So thank you for sharing that with us. All right. So just to close out, I know these were really fantastic cases, but go ahead and pick your favorite. So at least we can, I thought they were all great. So I'm not going to vote, but Let's just take another 10 seconds to get people's votes in. See if your votes match our votes. All right. All right, going to close the poll. All right. So like I said, I thought these were all really phenomenal cases. And I think that stab wound to the buttock, which I think is an oldie but a goodie, just really showing how basic used to a fast exam. But I want to congratulate all of our presenters and thank you guys for contributing and sharing. This was really fantastic. One second. So really, I just going to put up this slide one more time. If you haven't had a chance to fill out the survey, you can go ahead and you can capture it now. Sorry. I want to thank all of you for joining. It's really wonderful to see everybody and get together. Just a few thanks. I want to thank Sid Karash, Andrew Lateplo, Kelly Sobey, without whom really we would not have been able to get this presentation together. And of course, behind the scenes, Lorraine Lagasse, and of course, our wonderful P2E board. It's been really a great, under the circumstances, you're working with everybody. Wish we could have been together. And with that, somebody asked for the QR code again. I'll go back one more time. And with that, I'm going to close out our regular session, and then we're going to have Dr. Sam Rem take over discussing research projects. If anybody has any questions for me or for any of the other exec board, or let me know. Thank you.